Today we are talking about the bilateral cleft lip repair. Dr. Nicole will assist me with my slide sharing so that it's easy remotely. So Dr. Nicole, we may just go to our first slide. Yes, the next slide. Thank you very much. So the anatomy in the bilateral lip is of importance. And normally some of the glaring things are that the columella is shortened. So if you compare the bilateral and unilateral, in the bilateral, the columella is shortened. You also have number 3, the prolebium component is rudimentary and in most instances lacks the muscle. And then just like in the unilateral, the white roll is an important landmark, and that's 2, the white roll. And the point of disappearance of the white roll 4 is still an important landmark in the bilateral. We can go to the next slide, please. The anatomy of the musculature in the bilateral cleft lip is important. The importance, or what is important for us to know, is that there are 2 patterns of muscles. There's the circular, which is essentially the orbicularis oris, and that is number 1. So there's the circular muscle, and then there are those that come in radially. And those that come in radially, from number 2, 3, 4, we have the zygomaticus major, minor. Number 4, we have the levator labii superioris. And number 5, we have the levator labii superioris and cunasi. So there are 2 sets. There's the circular, and then there's the radial merging in. And we know that for these muscles, these are essentially muscles of facial expression. So they have an attachment to the skin. And that is important because many times when we do releases, you're going to release sometimes muscle off from skin. Next slide, please. The vasculature is important, and the arterial supply is mainly derived from the facial artery. But of importance to note here is that your prolabial segment gets its supply from your anterior ethmoidal branches that come from the internal carotid system, whereas the facial artery is from the external carotid system. So this is an area or a point where both the internal and external system are ramifying. And that is important because when you are doing the surgery, then you have the confidence in whatever you're going to do with the prolabial segment. And so the importance of this is just to note that the prolabial segment has an additional blood supply, good blood supply, and so we are not so worried when we touch into it. Next slide, please. Now, these landmarks are very key when we are doing the bilateral. These are the same landmarks we have when we are doing the unilateral lip. And so their importance cannot be overemphasized. So we'll go through one, which is the lower most aspect of your Cupid's bow, called the trough. That is one. We can go back. Yes, 1 is the lowermost point on your Cupid's bow, and it's called the trough. 2 is the peak of the Cupid's bow on one side, and 3 is the peak on the other. So distance from 1 to 2 is about 4 millimeters in Caucasians, slightly wider in Africans. If you look at 2, there's a line from 5 to 2, and there's a line from 4 to 3. The line from 5 to 2 is the marking that would be routinely done for Caucasian lips. The line from 4 to 3 is a marking I have adopted for doing African lips, slightly flaring, so that the Cupid's bow is African. And so,
les Africains surtout, quand je fais une réparation des fentes.
4 and 5 are the base of the columella. 4 and 5 are the base of the columella. The distance from 4 to 3 or from 3 to 4 should be about 10 to 12 millimeters. And that distance is mirrored on the side from 6 to 7, which should also be about 10 to 12 millimeters. So the distance 4 to 3, 5 to 2, and 6 to 7 should all be congruent. Those distances should be the same. 6 is the ala base. 7 is the point of disappearance of the white roll, significant in the unilateral lip and equally significant in the bilateral lip. And so 6 to 7 will go and match 5 to 2, and similarly that will happen on the opposite side. And that is the essence of the markings. Also, 3, 1, 2 is where I make my incision, as we shall see, so that it doesn't spare the patient's own Cupid's bow. Next slide, please. Thank you very much. So essentially, if we look at the marking in the bilateral, if you look at 1 and 2 on the left of your screen, is going to fit in 1 and 2 on the right of your screen. And what that means is that where 2 is, you are using that extension where 2 is to essentially come and provide the lip, the mid part of the lip. So you'll get one from one side and the other from the other. The filter in between your philtrum columns, you will derive that skin from your prolabial segment. So if you look at the lip between your philtral columns, you will retain that from your prolabial segment. But your lip at the vermilion, you are going to produce it by advancing from the 2 area on both sides so that you create your lip, which means the end point of your white roll, which is designated as we had discussed earlier, you're going to extend that end point of your white roll by about 5 millimeters on both sides. And those 5 millimeters is what is going to give you 2 in the picture on your right side. And so that is how you're going to create the lower vermilion lip. Next slide. Essentially describing the same. And what is important here is that you are going to use the mid portion of the prolabium, but you're going to insert from both sides elements of the lateral lip that will come and form your lip, especially the mucosa and the vermilion. The mucosa is simply elevated as indicated on the picture on your right, so that there are no completely released flaps. You'll have a flap that on one end, it's only released on one end, and that gives you a viable flap and prevents any fistula formation. Next slide, please. That is how the incision is done. Normally, you would use a sterile spatula, or I normally use an instrument to make the incision that in the mid picture is marked as 2. 2 is your mucomuscular flap that will now form the lower lip. That is your mucomuscular 2, or designated by A in the mid picture. And you're essentially releasing it by the first picture. You are releasing it by using an instrument so that the cut is through and through the mucosa and through muscle. And this is going to form the extension that will come in and form your lip. So in essence, you are creating the lower lip from that. Then the mucosa is okay. We can go to the slide you've gone to. The next, yes, thank you. So the mucosa, as we've said, we lift it, and only on one side in most of the instances I do, so that you avoid any dehiscence, any fistula. Then 2 on the picture on the right is the muscle. So once you have released the muscle, and release of the muscle is like that of the unilateral, so you have to go on both sides of the cheek area and release muscles just like you would do in the unilateral. But once you've released the muscle, the leading tips of the muscle go and attach to the base of the columella 2. And then you continue with the rest of the muscle 1 and 3 to the lower portion of the muscle. Next slide, please. And then once you have the muscle in, your suturing should begin downwards, going upwards. You first get the lip at the mucosa, vermilion and mucosa. That is the deep blue. Then you go to the light blue. And in the light blue, you do one side to the other. And the reason is when you go to the yellow, you will always have excess lip, which you will trim. And so that trimming will help you have a close, nicely fitting lip. Of course, the underlying muscle is the one that has taken the tension. And so you've done good muscular stitches for you to get the lip like that. Many times in Africans, you will end up with a slightly flared and collapsed nasal cartilage. And what I do is I use an ETT, endotracheal tube in theater, and just cut it short and use it to both support the cartilage as shown on the picture on the right, but I also, in addition, use it to grow the columella. Normally, the 1 or 2 weeks I use, probably in many instances, 2 weeks I used to do this. That columella will grow appreciably, and the cartilage will be well supported. And once you remove them, there's adequate support. I hold it nicely with sutures, about 3 sutures on either side, and that holds it well. And normally there's a special saline spray and suction that the patients are able to get, and that helps clean out during the time this child is recuperating, so that there's no blockage, and works very well for me. Next slide, please. And so you, based on the principles that we are deriving, some from the unilateral repair and those unique for the bilateral, we are able to get all parts together and get semblance of a normal lip from what has essentially been a defect. In other words, in most lips, everything is there. It's just us to figure out and to get them together. Next slide. Yes, we can go to the next slide, please. Thank you. So, and you can see in many instances and in our setup where sometimes the patients present a bit late, can have the prolabial segment jutting, but after the repair, you can see the prolabial segment, actually the lip will take it back by exerting that tension continuously, and that prolabial segment will go back. For patients who we are able to do nasoalveolar molding, we can, but for a number of instances, the presentation is such that we see them when that period is almost gone. And so we either just do the repair to push back the prolabium slowly, or as we shall see in the next slide, do a setback osteotomy in the same sitting. Next slide, please. This is just to depict the use of the setback osteotomy when we have the prolabium going haywire. The prolabium sometimes is unhinged and can go anywhere in either direction. And so we do a set to bring it into place. And when I'm doing the setback, because a lot has been talked about growth and the interference, so I try to avoid the suture lines when I'm doing the setback osteotomy, so that we bring that segment to control and we're able to get back the lip to where it should be, put stenting for the alar cartilages, and allow the patient to heal. Next slide, please. This is just sharing some of the experiences I've had. These are my patients who have operated on. And so you get balance and you're able to integrate these children into society. Next slide, please. The other aspect I've noticed in us Africans is many times you'll get a bit of scarring. So I have started using the sometimes contractubex, which I think is allantoin, heparin allantoin, to sometimes soften in case I notice that it's scarring immediately. And so scarring is something in Africa that many times we have to deal with. But with that use, the scars seem to soften and we get better results. Next slide, please. A bit of the scarring, but still you get acceptable results. Next slide, please. Good results, good growth, and we're able to integrate these children into society. Next slide. In some of the patients, you can see you totally don't have a scar. And you can see the nose is debatable because this is not a Caucasian nose, but I believe this is an African nose. And so I sometimes deliberately do my measurements when I'm reconstructing the nose to suit the African nose. Next slide, please. Yeah, and so we are able to integrate using those techniques. I believe this is the last slide in my presentation, and I'm very honored to be able to discuss my experience with you. Thank you very much, and back to Prof.
Thank you very much, Dr. Osundwa, for this very inspiring step-by-step lecture on the bilateral cleft lip repair. it's quite illuminating looking at some of your cases that you have treated. And I believe that we have learned one or two things from your experience over the years. We have some questions which I want to raise with you. The first one is from Dr. Abdullahi Jallo. And the question is, don't you release the skin and mucosa of the lower lateral cartilages during rhinoplasty? That's a question from Abdullahi Jallo.
Do I go ahead and answer, Prof?
Yes, just answer. Go straight and.
Thank you. Thank you. So, Dr. Abdullahi, when I'm doing the bilateral lip, many times I don't release the cartilage in the bilateral, because if you look at the anatomy of the bilateral lip, the cartilages are not as displaced and flared as in the unilateral. You see, in the unilateral on the cleft side, the cartilage is lowered by the deformity. But in the bilateral, centrally, the cartilages are unified. And so the only problem in the bilateral normally for me is cartilage support. The cartilage is a bit collapsed. So when I do the repair with a little bringing in of the ala basis into the midline, with the ETT, the endotracheal tube support, the cartilages do very well. And so I don't need to do open rhinoplasty. Indeed, rarely have I had to do open rhinoplasty for bilateral. I do open rhinoplasty sometimes for some unilaterals. In many of them, I do closed release for the ala cartilages in the unilateral, but rarely have I done open rhinoplasty for the bilateral. Thank you, Prof.
Thank you, Dr. Osundwa. Another question from the same person, Dr. Abdullahi Jallo, is asking, how do you do the setback osteotomy?
I use the stalk. Normally, the prolabial segment has a stalk, and I make a stalk incision the way one would do a crestal incision when you're doing alveolar surgery. So I make it at the base, at the top of the crest of that prolabial segment. And so the incision runs longitudinally anteroposterior, and that normally, with release of the mucoperiosteal flap, should give you an immediate access to the bone that is forming the stalk. And you'll see many times two sutures. And so I avoid the sutures, and I can take the bone in between. And I use a bone nibbler. I just nibble it, and as I nibble it, I keep pushing the prolabian and see that it is sitting well. Once it's sitting well, then I go back and suture. That bone, if you want to use it to insert it around and probably let it integrate, you can do that. And then you are done with your setback.
Thank you. I hope that answers Dr. Abdullahi's question. The next question I would like to ask is from Dr. Ilori Oluwatosin. Says, thank you for the presentation, sir. Say, how long do you put the nasal stent? Have you had any complication arising from the nasal stent?
Yes, I think it is important to educate the parents very well about the nasal stents. And I must also point out, as you have seen, when I do like when I do 5 cases, it's probably 1 or 2 that will actually need stenting. I don't do stenting for all of them. Many of my bilateral lip repairs, with just adequate repair, I'm able to make the assumption that the cartilage, or look at it and agree that the cartilage is well supported. But in those that the cartilage is collapsed, which is 1 to 2 in 5, then I go in for the stenting. When I go in for the stenting, I really have to educate the parents. I also have to review this child. Nowadays, it's a bit easy with the communication levels, but I have to review this child very frequently. I leave these stents between 1 to 2 weeks. 2 weeks in cooperative children, 1 week in those children who become intolerant. The problems are mainly if there's no adequate cleaning. Normally there's a special spray, saline spray, that at the same time is used for suction. You press it, it sprays, and then you release it, it sucks. And so that is very effective in terms of making it clean and making sure there are no plugs, mucus plugs or blood in it. And most of the times between 1 to 2 weeks is adequate for me. And it's surprising that by that time you'll find the cartilage is very well supported.
Thank you, Dr. Osundwa. Now we have another question from anonymous attendee. It says, thank you for your succinct presentation. Say the skin sutures, what do you do? What do you use for the skin sutures? And are they removed later?
No, and I know different people. If you look at I've written a book on cleft lip, and I'm happy and thanks Smile-Train that they've adopted this book. And if you look at it, you'll find I talk about the type of sutures I use. I normally use 4-0 throughout in children because I've found that it gives me, I'm comfortable, does not open easily, gives me the strength, especially when I do the muscle with 4-0, adequate strength so that the skin is just sitting. I don't go back to remove my sutures. I normally educate the parents on how to clean the wound, and as they clean, these sutures fall. I also don't do any dressings on the lip when after surgery. I only use mupirocin, Bactroban, either mupirocin, they can use tetracycline, ointment, or other insoluble emollients like Vaseline. Otherwise, I just leave it open, and I normally use 4-0. But I believe the choice of the suture should be the surgeon's choice. People have different preferences. I use Vicryl. I know some people use nylon, and then they have to go back to theater to remove the stitches. I don't do that. I just use 4-0 Vicryl and allow them to fall.
Right. Thank you. This question is from Sunday Olusheye. He says, thank you for your presentation, and said, following the osteotomy, how is the segmental bone stabilized after setback?
Normally, after the setback, that bone will reunite with the edges, but the stabilization is with the lip. By the time you're putting the setback, you find when you do adequate suturing, especially of the overlying mucosa, if there's any excess of the overlying mucosa, you can trim a little bit so that your mucosa is holding that bone that you have removed part of very solidly, and that bone does not move and normally integrates very well. I don't think you need to fixate it. You don't need to use any external fixation.
Okay. All right. Thank you very much. The next question is in French. Maybe Dr. Capochichi can help us translate that in French. I mean, it's written in French, so and my French is not very good. So I hope the translation can be done so that Dr. Osundwa will be able to answer it. Dr. Capocici.
Yes, I'm here. We do have a question in French that I will translate. So, I'll first read it in French. Merci, Dr. Osundwa, pour votre exposé. Pour les fentes bilatérales complètes, quand est-ce que vous envisagez une alvéoloplastie? So the question is from, the name was not identified. So he's thanking Dr. Osundwa for his great presentation. And he would like to know for the bilateral cleft, the complete bilateral cleft, when do you envisage or when do you do the alveoloplasty?
So for the complete cleft, there's the concept of gingival perioplasty now, which just means preparing the gingiva to essentially have very good areas of placement for your bone grafts, alveolar bone grafts. And so when you're doing the initial surgery, you may want to kind of prepare the soft tissue pockets. For the bilateral, is not as easy as the unilateral. If you look at my book, in the unilateral, I give a basis for preparing the pocket later for the alveolar bone graft. For the bilateral, you may do that, the gingival perioplasty anteriorly, and later on, you may want to go in and put bone inside, depending on the degree of the bone defect. Many times from 4 to around 10 years, depending on various factors, we're able to go and put bone in these segments.
Okay, thank you. I'll translate that.
Thank you very much.
Au participant qui a posé la question, pour les fentes bilatérales complètes, elle est souvent difficile, mais l'objectif est de pouvoir préparer les gencives. Il y a une technique qu'on appelle je vais essayer de traduire, gensivoplastie. Ça, je la traduis vraiment directement en anglais, en français, gingivoplastie, où le concept est de préparer les gencives à recevoir l'alvéoloplastie. En unilatéral, elle est plus facile qu'en bilatérale, quand on a une fente bilatérale. Et donc, quand on fait la réparation de la fente bilatérale, il faut profiter pour préparer les gencives à recevoir l'os ou à recevoir une greffe d'alvéoloplastie, a fait cette greffe-là. Il a bien décrit dans son livre, le professeur, le docteur Tom, et l'important, c'est que quand vous faites une fente bilatérale et que vous savez que vous allez avoir à faire une alvéoloplastie, il est très important de préparer les poches de tissu qu'il faut pour recevoir l'os, pour recevoir cette greffe d'os-là. Et aussi le temps, l'âge de l'enfant, on peut déjà penser entre 4 ans à 10 ans. Elle n'est évidemment pas la plus facile à faire, mais elle est possible si on utilise ce concept de gingivo-alvéoloplastie. Okay.
Thank you very much.
Done for...
Oh, okay. Sorry, go on, doctor.
No, I'm done. There is another question in English.
Okay, okay. There's another question from Dr. Abdullahi Jallo. He says, thank you very much for your wonderful presentation. He says, what is the title of your book, sir?
My book right now, Smile Train is providing it. I think we'll provide it for free for surgeons who are partners with SmileTrain in Africa, because SmileTrain has, I've partnered with SmileTrain for a special edition of my book, and they have had this special edition for specifically targeting surgeons who practice in Africa. So the book is Cleft Lip and Palate, a practical guide. And part one of the book is basically cleft lip and palate. It's a practical guide. This book has techniques that we have developed for the African lip, and I think that is why it is important for us to look at it. But I believe SmileTrain has been giving in, for instance, in Kenya, they are giving trainees for free, and I believe they are making copies to be able to supply everywhere. I know there was a good friend of mine, surgeon from DRC, if he's in this forum, SmileTrain is organizing to have them posted to DRC. And I believe that this resource will be freely available through SmileTrain. I don't know, but I think that will be the position.
Thank you very much, Dr. Osundwa. I think we have exhausted all the questions in the question and answer box. I just want to appreciate Dr. Tom Osundwa for that very, very educative and informative lecture. You have taken us through the practical steps. And I believe that we have learned one or two things about this lecture. So once again, I want to thank all the participants. I can see we have over about 55 attendees, and I believe that we have gained one or two things. So thank you, love. Thank for the opportunity given to me to moderate. I would like to hand over the proceeding to Dr. Kapuchichi.
Thank you so much, Professor Olayinka. Thank you, Dr. Tom Osundwa, for the wonderful presentation. Dr. Nicole, who is part of our team as well, would like to share very important information before we close this session. Thank you all for attending.
Thank you, Dr. Tom, for this very educative lecture. Thank you, Professor Olayinka, for the moderation. We are very grateful. So before we close, I would like us to know that we will soon end the series 3 of Telecleft initiative. And we are so happy, we are so grateful for your participation. We will kindly let you know that we will continue our journey with the series 4 starting on January 4th. And this time it will be every Monday. So please stay in tune, and I will provide more details next week. So please invite your colleagues, your friends for our last session next week. And concerning the CME points, I will also share with you the CPD points. You will be kindly requested to fill in the form and send it back to me. So thank you so much, and I wish you a very nice day. Thank you, everyone. Bye-bye.
Thank you.
Thank you very much.